Good morning, Breakfast Clubbers. Cleft lip is a significant problem throughout the world. In the US and other industrialized countries, cleft lip surgery and the aftercare is readily available. Unfortunately, in other areas of the world, the surgery and aftercare for cleft lip may not be readily available. As part of his plastic surgery training, Dr. Kim learned how to do this life-transforming outpatient procedure and has traveled to various countries throughout the world to donate his skills and time to help children smile. Dr. Kim will be talking about cleft lip and fun times in various countries he's visited to help the children and what we can all do to help. Dr. Roy Kim is a board-certified plastic surgeon in San Francisco. He focuses on aesthetic surgery, especially of the face and breast. He loves to share his enthusiasm for plastic surgery on social media and looks forward to traveling again someday to help more children smile. So let us give a big welcome to Dr. Roy Kim.
Thank you. Thank you so much. So thanks again to Tom Kowalski for having me as a guest. My name is Dr. Roy Kim. I am a plastic surgeon in San Francisco. I have, just like other people, have trained a lot in cleft lip and cleft palate. He wanted me to focus about cleft lip because it is an important issue within the US and outside the world. And also, it has actually some social, political ramifications. So this is all my contact information. Sadly, I'm in Union Square, very close to where you actually have the physical meetings, which may or may not occur anytime soon. So what is cleft lip? Cleft lip is a genetic issue where the muscles, skin, and all the structures don't form properly in the womb. So in the US, about 1 out of 2,800 live births or children are born in the US with a cleft lip. In other words, cleft lip only, not a cleft palate. Cleft lip is technically through the lip, part of the lip, the entire lip, going into the nose, part of the nose, the entire nose. So there are different degrees of how good or bad it is. It is genetic. The only thing that we know that it's related to is folate deficiency. This isn't a huge problem in the United States because of prenatal vitamins. This is a bigger issue in the second and third world. So in other words, although there's a higher incidence, higher rate in the second and third world, it's not necessarily ethnicity or genetics or any other issue. It's really lack of folate in the prenatal diet. The nice thing about cleft lip is that it's a highly fixable outpatient procedure. So one outpatient procedure, boom, it's fixed. There are issues occasionally with physical therapy, occupational therapy, or speech therapy with the actual lip. But in general, interestingly enough, especially children do quite well with little therapy. With speech therapy, a lot of times these countries just don't have any speech therapists. I've been to Malawi in Central Africa. There are 2 plastic surgeons in the entire country for a country of approximately 8 or 10 million. So I was the 3rd plastic surgeon for a couple weeks. In Myanmar, there are 6 plastic surgeons that are qualified in a country of about 46 million people. So they are swamped with work in general related to burns, reconstruction, cleft lip, and they have no speech therapists as far as I know, and they know. So this is also getting into one of the sort of existential questions about plastic surgery. What's reconstructive and what's cosmetic? So this is a picture of a normal lip. We have to know it's normal, and we have to know it's beautiful to be able to reconstruct something that is not normal. So we do know the structures of the lip. There's a circular muscle that goes around. Obviously, it's important for, the most important thing I think is kissing. Of course, there's talking and eating and facial expression, but all those things are vital in terms of how plastic surgeons think about using your lip and reconstructing it. So some problems are completely cosmetic, some problems are completely reconstructive and functional, and you have to have a blend of thinking of both to really get the best result. There is a massive amount of prep work related to cleft lip surgery. So I had no idea. I've been on about 6 medical missions. The first 1 or 2, I had no clue how much prep work is required. Just because there's a need in a country doesn't mean that people will come. So if you build the baseball field, they're not going to come. You have to tell people through broadcast media through the churches, through community groups, that a group is coming. Then you have to arrange for transportation. Some of these countries do have free healthcare, but that doesn't mean that they provide any transportation or housing at all. So a lot of the logistics, money, donations go towards that. And of course, a lot of the patients are children. So you have to make sure that the hospital is actually equipped to do pediatric anesthesia, pediatric aftercare. So before we even arrive there, there's been a massive amount of prep work. So this is one of my trips to Blantyre, Malawi. This is the business city of Malawi. Central African Republic is the very old name. So the kids are just wonderful. The staff is wonderful. The hospital is excellent quality. I personally would get an operation there. So I felt very comfortable operating. This is from a trip to Port Moresby, Papua New Guinea. So these are two brothers who had cleft lip, and this is after their repair. What's interesting about cleft lip is that classically in the US and in the first world, it's repaired as an infant. So what happens is in other countries is that sometimes these cases slip through because there aren't any plastic surgeons to actually deliver the surgery. So these children obviously are not infants. They should have been operated on sooner. There just was no one around. This is in Blantyre, Malawi. This is a little baby and her mother who both had cleft lip. So I actually repaired them both on the same trip. So you could have unilateral or bilateral cleft lip. Unilateral is on one side, left or right, bilateral is on both sides. So I reversed the pictures. The after result is obviously on the left, but the before result you can see, this is a complete unilateral cleft lip. It goes completely through the lip and into the nose. So with cleft lip, as you can sort of tell, there are issues with the nose as well. So you can see the repair, which is not healed up obviously, and I've actually put some yellow gauze around the nose to try to conform it or put a little pressure dressing to help mold the nose. And these are some of the patients that I saw at Papua New Guinea. They had a nice going away party at the end of the trip. So this is an interesting case. This is probably the most touching, memorable case I've ever done in terms of cleft lip. This is an adult who has bilateral cleft lip. So you can see him at the time of surgery on the left. There he is with his wife and his son on the right. So he looks actually relatively normal. So he's a good healer. And bilateral cleft lip, long-term, the issue is that the middle of the lip sort of lacks any fullness. So that can be corrected with additional procedures. The reason why this is so touching to me is that, of course, I don't know the native language. And the nurses all talk to the patients and the patients' families. And so what the wife said was, she was crying at the end of surgery. And of course, that happens a lot. There's a lot of emotion. There's a lot of happiness with these procedures. What she told the nurses was, she felt that he was handsome on the inside. And he was just a great guy. So in their village, they fell in love. And she was warned, number one, not to marry the guy, date the guy, then not to marry the guy. Then, of course, why are you having kids with the guy? All your kids are going to be deformed. Well, it's not necessarily passed on every generation. There's an increased genetic risk, but there's no other massively increased genetic risk. So, of course, the baby boy's healthy, and she always wanted him and pushed him to get it fixed. And of course, there weren't that many resources. So they saved their money over a couple years. And when the next trip came through, the next medical mission, they drove down to Blantyre, Malawi, and had it fixed. And she was crying because not only did he look so handsome, but she also said it's the first time that they were able to kiss in their lives because he had never been able to do so. So that's what she was crying for. And she never told me this, but I heard about it later near the end of the trip. And it was a very, very touching story. This is another young mother with her baby in Blantyre right after surgery. And so you can't really replace the smile on the family members. I mean, of course, the kids smile and everything like that, but it's really the whole community and family that does better. With adults, there are definitely more issues with healing. It's more difficult to reconstruct the cleft nose in adults. Even if you fix the lip completely beautifully, the actual muscles of the lip never fully recover. In children, they can, but even then, it's not a guarantee. In adults, it doesn't matter what I do or what speech therapy the adults get. Sometimes they just don't have symmetric normal movement of the lip. There's also more noticeable scar in adults. So as you can see here, he actually has that nice Cupid's bow on the left side, which I recreated. However, I do think that long-term, he probably will not have fairly normal lip motion. Even though this talk is about cleft lip, it is intimately related to cleft palate. And to me, this is a much bigger issue. Cleft lip, weirdly enough, is a little more cosmetic. It's a little less functional. A lot of people can still eat. There's no connection between the mouth and the nose. With cleft palate, there's a hole in the roof of the mouth. So it can be a small hole, it could be a big hole, it could be complete lack of any barrier. In other words, you have no roof of the mouth in a segment of the top of your mouth. And so it's very easy to get food between and communication between your mouth and your nose. As an adult, it would be very annoying. Obviously, you can learn how to eat or drink properly. Obviously, if you're a child or a baby, that's an issue. So babies are constantly spitting up. They're having food go in all the wrong place. If they have a cold, then all the mucus goes into the mouth and the baby's not happy. So this is a huge issue. The other problem is that you can't actually speak properly. So especially with diphthongs like the f and t noises, there's certain sounds in all languages where you put the tongue at the top of the roof of the mouth. If there's a hole there, you actually cannot make that noise. So patients have a lisp, and there's certain sort of language sounds that they actually can't make. So this requires not just repair, this actually requires speech therapy. So with cleft palate, you can have it one side or both sides. It can be combined with cleft lip. Sometimes you just have an isolated cleft palate. It occurs in 1 out of 1,700 live births in the US. And again, it's a slightly higher incidence in third world due to lack of prenatal vitamins. So it's a much more difficult functional issue. It's often ignored by charities. You also need more touch-up procedures or long-term procedures because typically you need bone graft long-term. Just because you cover it up, that's great. And you do need to put in bone graft at the roof of the mouth, which typically you do as a teenager. So with the cleft nose, it does require multiple procedures. Just to fix it, that's what you do as an infant. To make it actually look semi-normal to normal, that requires more procedures. You may have heard of deviated septums, the cartilage that divides the right and left nostril. So on the cleft nose, it's going to obviously deviate or lean towards the area that has the cleft. That can then introduce problems with breathing, sinusitis, allergies. That becomes functional. It's no longer cosmetic. The structures in the nose are often weaker, shorter, or not actually there. They're not normally formed. So multiple procedures often extend to adulthood. And even in the US, sometimes it's not covered under insurance because they consider it cosmetic. So this is where, again, the existential question of what's cosmetic and what's reconstructive comes into play. So this is, I left this slide purposefully fairly blank because it's slightly controversial. I mentioned that cleft palate is ignored by charities, and that for the most part is true. Cleft palate is more functional. Cleft palate's actually not visible. It's easy to see a cleft lip. You could see the photos yourself and the videos yourself, but a cleft palate's on the inside of the mouth. And that actually gives a lot more issue with speaking and eating. It requires much more speech therapy. It's a much longer haul to take care of. So Operation Smile was started by a plastic surgeon. He was moved by his patients when he went on a medical mission to the Philippines. It's now the largest cleft lip and cleft palate charity in the world. Some people were grumpy at Operation Smile, so they started Operation Smile Train to confuse everybody. But they do a good job as well with cleft lip and occasionally cleft palate. They, in the third world, are duking it out, competing for cleft lip patients. So it's what you remember when I talked about preparation before any medical mission trip. So there's advertising, there's radio ads, there's charities in these countries where people say, hey, we're coming on this date to this city, there's no charge. We're going to give you and deliver you cleft lip care. Typically, they don't want the cleft palate patients. They will say, well, why don't you come when the other charity's coming into town? So I know that they're doing a little less of that, but certainly in the past, let's say 10 years ago, 15 years ago, that's what they were doing. And there are lots of smaller charities or individual plastic surgeons that just go on a medical mission. And it's harder, and it's becoming increasingly harder to get those cleft lip patients for the pretty pictures. Operation Smile and Operation Smile Train do have actual employees now in multiple second and third world countries. It's a vast charity infrastructure, and they're doing a great job. It's just that it's interesting to me that there is competition in that field, when I would think as a human, you just want to pull together and just deliver the best care possible. I think it just shows that despite our good intentions, sometimes humans get in the way of doing the best job possible. India has done a very interesting job. They do take the training from Smile and Smile Train, but there is a dedicated cleft lip, cleft palate hospital in India, and it is huge. They're going through thousands, tens of thousands of cases a year, and it's a very impressive facility. Their surgeons become so good at this that they're doing it at, much more efficiently with video speech therapy out in the rural communities of India to ensure that these patients do well. So I definitely think that that is the model, as well as telehealth. It's been around for a long time, but certainly video health and follow-up will continue to actually improve cleft lip and cleft palate care. The other funny thing to me is that I've actually kept in touch with some of my patients through Facebook. So it's pretty hilarious to me and very touching when I get messages from patients I operated on a couple years ago, 6 years ago, 12 years ago, see that they're doing well. It's a very, very, wonderful thing to have social media and be in touch with them. So that is the extent of my talk. If you want to find out more about me, I have a website, I'm on Instagram, I'm on Twitter, and that's really about all I have to say about cleft lip and cleft palate. It's a lot of fun. It's a component of plastic surgery. I hope you enjoyed it, and I hope you realize that every field has their sort of niche esoteric thoughts, and one of them about plastic surgery is what's functional, what's cosmetic.
All right.
Dr. Roy, I have a question, if I might. This is Rick Wilson. Sort of logistically speaking, how many days is the mission? How long does each operation take on average, and how many do you do a day when you're on these missions?
Typically, I like to be there for about a week. And so we hit the ground running. I'm going to see a lot of patients in clinic the first day or two and arrange for surgery. Then the first couple of, like the second day, day 3, day 2, day 3, day 4, I'm going to be operating up a storm, making sure the patients are doing well. Day 5, day 6, I'm tapering down. And by day 7, day 8, there's no surgery. I just want to make sure that everybody's okay. And I will stick around for a couple days in that town to ensure that people are doing well. Typically, this is a pretty short outpatient procedure. This takes about an hour, hour and a half. So we're typically, we're operating like 10, 12 hours a day. So the number of cases depends on the type of case, how hard the case is, and how much we can bribe the local hospital staff to stay overtime. So in a week, we'll do about 40 to 60 cleft lip patients.
Thank you, sir. Wow, incredible.
I have a question. What's the infection rate?
The infection rate is thankfully pretty low. And the reason why is that cleft lip is in the mouth. So the mouth is technically the dirtiest part of the body, bar none. It has the highest bacterial count. And so it doesn't matter how much you clean the inside of the mouth with surgical soap, there's going to be some bacteria in it. So with cleft lip, we use that to our advantage. Of course, we follow surgical standards. It's just that, when you're operating on the nose and mouth, you can only get it so clean, even in the United States. And so the body just knows that. And so if you have a cut on the inside of the mouth, we can fix it. It doesn't really get infected that often. Same with the cleft lip.
Dr. Kim, there's been some questions in our chat regarding folate and where does it come from, and just a few general questions associated with that. Maybe you can go over that as well.
Yeah, folate typically comes from green leafy vegetables. You have to eat a decent number of vegetables. I wouldn't even say decent, just an average number of vegetables to get enough folate if you're a pregnant female and, avoid prenatal deficiency. Of course, because you may not be eating enough green leafy vegetables, it's not a bad idea to supplement with folate by pill form.
All right. What other questions do we have? Patricia, you always have a question.
I have a question.
Betty, go ahead.
Thank you for your very nice presentation and the work that you do. It's so important. I used to contribute to the Smile Train a lot. One of my clients was very active in it. My question is, what's the incidence of keloids with scar formation and so forth after with the population that you're working with? And then secondly, after you leave, and yeah, I'm sure that there's a competent staff to remove sutures, or do you use sutures, or how does that work?
Yeah, so keloid scars, just in case some other people don't know, keloid scar is a scar that is too big, too red, too wide, too thick. Typically, it occurs on the face, neck, and shoulders. Also, it's related to ethnicity. So if you have darker skin, you are more prone to keloids. So that includes Hispanics, Asians, Africans, African Americans, actually Caucasians who are from Italy, Spain, Portugal, the Mediterranean. So you're more prone to keloids. So obviously in Africa, people are definitely more prone to keloids. Unfortunately, there's not much to do about it because right after surgery, there's going to be no keloid. If you're from a very rural area, it may be hard to get follow-up care and to just get a cortisone injection, which really helps with keloid scars. So in the US, even in the second world, even if you're in the third world, it's not that big a deal to come in once a month and get a suppressive cortisone injection to prevent a keloid. But if you're out in the middle of nowhere and there's no cortisone around, then yeah, it's a problem. In terms of follow-up care, this is where the prep beforehand comes into play. You have to make sure the operating room is good. You have to make sure you have pediatric anesthesiologists. You have to make sure that the recovery room nurses are good. Well, you also have to make sure that the aftercare is good, which is why I personally stick around. I think every surgeon sticks around for a couple of days, not operating, just to make sure that everything's healing. And of course, we do rely on hospital staff for suture removal. The second part of the question is absorbable versus permanent suture. So absorbable suture, your body dissolves it. And it sounds cool, and we use them all the time for areas underneath the skin that are really not visible. As a plastic surgeon, though, we're not big fans of absorbable suture at the skin level. The reason why is that your body can absorb it, but how does it absorb it? It attacks the suture, it dissolves it, and it breaks it down, and breaking it down causes more scar tissue potentially. So when we're really close to the skin, we actually love to use permanent suture. There's no tissue reaction to permanent suture. It's permanent. The body cannot break it down. Technically, if you don't remove the stitch, technically that suture is gonna be there forever. So we have to remove stitches. That's what we like to use at the top level. In other words, the visible level of skin. So that is an issue because for cleft lip, the stuff inside the mouth, the stuff like connecting the muscle, that's absorbable. But the part that you see with the eye, the part that is exposed to the outside world, we use permanent, and someone has to remove that suture.
Thank you.
Patricia, you have a question?
Well, yes, and thank you for a wonderful presentation and for the good work you're doing in the world. And certainly when it comes to considering medical or cosmetic, the mental health and self-esteem that must be added, it cannot be, can't be emphasized enough. It's good mental health. I would like to know, what was the moment that you decided this was going to be your contribution to the world?
It's funny you mentioned that. A more established plastic surgeon invited me to lunch and said, hey, our main plastic surgeon on this medical mission to Guatemala can't go because he's having, surgery and he has to recover from his knee surgery for a couple months. So would you mind going? I never thought about it, but I said, sure. As part of our training, obviously we do a lot of reconstructive stuff. So it was very mind altering, very life altering. And I should think about it more because, the way that people live in the rest of the world. They don't have water. They don't have great shelter. They have almost no clothing. And so they have a lot of misconceptions about even me, the medical mission, all those things. And so it made me realize what a spoiled person I was and all the things we take for granted. And I'm going to start talking about every cliche that you and I have heard about and read, including being present in the moment and being thankful for what you have and being grateful. And that all hits me every time I go to these countries, but also hits me every time I think back on those patients and the way they live. There are misconceptions from them. I mean, they think that we're being paid to operate, and they had a hard time really understanding, I paid for the trip. I'm not making a penny. I am using vacation time to operate on you. All the nurses and the staff, they're volunteers. All the surgical supplies are given as a donation. The hospital has donated their time, their operating room, their nurses to just give care. And it requires, free money, in other words, charity money, to pay for all that. So that concept in the second and third world often doesn't exist. To me, that's a very either first world issue and honestly, probably a very American issue. There are other countries that obviously have medical missions that donate their time to do these sorts of things. But America by far is the biggest country in terms of money, number of missions, number of surgeons, number of nurses. I mean, it's just astounding. Other countries simply don't do it as much. So, just as a human, it's a very interesting, life-changing topic.
Dr. Kim, we have one more question from Antonio White, and it's 8:30 now. So Antonio, why don't you wrap it up with your question?
Sir, thank you, Mr. President. Dr. Kim, what an incredible presentation. Thank you so much. And you ended in a big mind-blowing concept for me, this idea of cosmetic versus functional issues that you deal with your patients here. And I just even apply that concept to my own business. You could almost put whatever industry that you're in, and the idea that things that are cosmetic related to it or functional related to it. And what was it about that distinction between cosmetic and functional that connected with you? Why did you make that such an important part of this talk?
I think there's a misconception of what plastic surgery is, because I do mainly cosmetic surgery, but even within cosmetic surgery, there's a reconstructive element. The other thing is that it actually just as the last question, I can't remember your name, sorry, but it's about confidence, self-esteem. So when you can restore that, that means a lot to me as a doctor, but it means more to the patient. So we're talking about, breast reconstruction, scar revision, burn care. I've had patients who've had bad acne scarring and I fixed it like cosmetically. And I've had 2 patients cry. And honestly, one scar was really insignificant. Like you could barely notice it, but it just had bothered him so much. He had been teased about it as a teenager. He's a young adult. He finally got it fixed. It looks great. And it was like, honestly, I thought it was a bit of an overreaction. But to him, he had built it up into a mountain, even though it really was a molehill. So you don't know what's going on in people's minds. You don't know how they see their body. And that's true not just for plastic surgery. It's true for everything. Like architecture, interior design. You have a chair. Why do you care what the chair looks like? Maybe it makes you happy. Maybe it's not just functional, but aesthetic. And that applies to everything.
Thank you so much.
Well, Dr. Kim, thank you for joining us today. And it was a great presentation.
Oh, thank you. Thanks for having me.
Fantastic. And we'll keep the meeting open for a little bit longer if you guys want to stick around. And Dr. Kim, if you would like to answer a few more questions, I'm sure we have a few more. And also I'll make a moment to announce next week we have Barbara Barrington-Paria. She's going to be talking about Save the Delta. So Joel, you want to just give us a quick overview of what to expect next week?
Yes, well, we're in the battle for our own lives right here in the Bay Area, the water that we need so desperately, and the ways that Southern California would like to have it. And we will hear this week coming up about the incredible battle this one single woman has been fighting for years. And she's put on such an incredible battle that she has held back 2 governors now, maybe 3, in her time. So get ready to hear a real heroine in our midst. Thank you.
All right. Thank you, Joel. And with that, I'll call this meeting to a conclusion. Thank you for joining us at the Golden Gate Breakfast.